Hi all, this is Dr. Reshmi. In this video, we are going to see about enteric fever. It is also called as typhoid. Introduction. Enteric fever is caused by Salmonella typhi. Incidence 7.6 per 1000 person years in the age group of 1 to 15 years and the estimated prevalence being 6 to 8 million cases per year. Pathophysiology. Water and food contaminated with Salmonella typhi from a human carrier is the proximate cause. Ingestion of more than 10 power 5 bacteria usually causes the disease. The incubation period usually ranges from 8 days to more than 3 weeks. After ingestion, the bacteria invade the intestinal mucosa and proliferate in the lymphoid tissue, following which secondary bacteremia occurs and there will be invasion of gallbladder and Peyer's patches in the ileum. The Peyer's patches get swollen and becomes necrosed with formation of slough. During the second or third week, separation of slough takes place and result in formation of ulcers. If ulcers are deep, erosion of blood vessels and or perforation of gut wall can take place. Clinical presentation. The patient usually presents with loss of appetite, malaise, frontal headache, fever, which is usually stepladder pattern of fever, dry cough and diarrhea. Signs. The patient will be ill-looking and toxic, febrile, bradycardia, tongue is coated in the center and is raw at the tip. There will be tenderness in right iliac fossa, spleen will be palpable and there will be presence of rose spots in the abdomen, usually from 7th to 10th day. Atypical presentations. Sudden onset of fever with patient passing into a semi-consciousness or unconsciousness state in case of encephalitis type. In meningitis type, clinical features of drowsiness, headache, neck rigidity with normal CSF will be seen. Abrupt onset with features of septicemic shock. Onset of urinary symptoms consisting of renal pain, hemoglobinuria and hematuria will be seen in case of nephrotyphoid. Fever can also be associated with jaundice. Relapse. Recurrence of enteric fever occurs in 5 to 10% of the patients after 7 to 14 days of defervescence, milder than the initial attack. More than 2 relapses are uncommon. Complications include coma, intestinal hemorrhage, intestinal perforation, necrotizing enterocolitis, disseminated intravascular coagulation and enteric encephalopathy. Diagnosis. Total and differential count shows leukopenia and neutropenia. Blood culture will be positive. Bone marrow aspirate culture is the definitive test for typhoid fever. Polymerase chain reaction and Vidal test can be done. Typhoid ELISA kit also confirms the diagnosis. Differential diagnosis includes acute malaria, urinary tract infections, acute viral fevers like infectious mononucleosis and cytomegalovirus infection, and early tuberculosis. Management. Fluoroquinolones and third generation cephalosporins are the drug of choice. Fluoroquinolones such as ciprofloxacin 500 mg or ofloxacin 400 mg for 10 to 14 days in uncomplicated typhoid. Third generation cephalosporins like ceftriaxone 1 to 2 grams for 7 days is equally effective. Fluoroquinolones are contraindicated in pregnancy. Relapse is treated same as primary attack. Dexamethasone 3 mg per kg IV followed by 1 mg per kg 6 thali in severe typhoid with altered mental state or shock. Prevention. Observing proper sanitation, ensuring safe water supply, Public health legislation designed to ensure uncontaminated food materials should be followed. Vaccine for prophylaxis, live oral TY21A and purified 6 polysaccharide parenteral vaccines are available. However, they do not provide complete protection. Thank you. Please like, share and subscribe if you like this video.